Good afternoon all. كل عام وانتم بخير برمضان كريم. Happy Easter for our friends. So again, we are now presenting the new modules of the ABC educational courses. And on behalf of Arab Medical Association Against Cancer and Cancer Research Group, we are welcoming all of you. And we'll present today the hematological module number 1, which will be about the therapeutic strategies in ITP according to the latest guidelines. The course and the lectures are translated to French. It's endorsed by Arab Medical Association Against Cancer, UICC and ASCO, and it's awarded by 2 CMEs. So we'll present our first speaker. The lecture will be recorded. Regarding the quiz, we'll keep it to the end of the session. And our first speaker, Dr. Khalid Ibrahim. Dr. Khalid Ibrahim is Clinical Associate Professor of Hematology Oncology at Beirut Arab University, Lebanon, and he will talk about insights on chronic ITP pathogenesis, a bench to bedside update. So please, Vanessa, would you like to start?
So good day. I will start by thanking Dr. Farhat and Dr. Khatib for having me in this nice session. Next slide. So without due prolonged introduction, I will start by this slide. What do we know about ITP in 2022? Next slide, please. Well, first of all, let's start by having some housekeeping definitions. ITP, and this is for our non-hematologists and for our juniors. ITP, it's still ITP, but it's no more idiopathic. This is one. And in the new nomenclature, it's no more purpura. Why is it so? Because we don't know that this disease is not idiopathic. And on the other hand, we know that a minority of the patients, or let me be more specific, 30 or 40% of the patients with ITP do not present with purpura. This is one. The second thing, that the cutoff of thrombocytopenia is no more 150,000, but it's more 100,000. Next slide, please. And going back to the history of ITP, I think you all know the experiment of Harrington in the 50s, where in the classical paper, he presented that the passive transfer of ITP and ITP plasma, which means that when you take in plasma from an ITP patient and you give it for a normal individuum, it can cause thrombocytopenia. Next slide, please. And we know now that ITP is due to increased platelet destruction. And in this very nice diagram, you see on the left side, macrophage containing one platelets, seen in the red arrow. And if you look at the left side of the slide, you see a platelets being engaged in macrophage to be endocytosed. Next slide, please. So what I'm going to try to do now is just to explore the new pathway in the ITP pathophysiology. I will take the most pertinent ones and that have an impact on the clinical and treatment setting. Next slide, please. And I will focus on 3 pathways. The first is the role of the complement activation. Next slide, please. Now, the classical complement activation and autoantibodies result in deposition of complement component C3b. This is a very important surrogate on platelets surface, and ultimately it results in phagocytosis by macrophages, mainly in the liver, as you see in the left part, of the right part of the slide. Next slide, please. The complement system is a component of the innate and adaptive immune system. There are three pathways: the classical, the alternative, and the lectin one. And the classical complement pathway is activated via the C1 complex by immune complexes that contain complement fixing antibodies. And this, at the end of the day, it results in an attack of the membrane of the platelets and subsequently to cell lysis. Next slide, please. As you will see here in the right circle, that's how the classical system starts, and it ends up in the bottom by membrane attack and cell lysis. So this is a very important part of information in the new concept philosophy, or the new philosophy of the pathogenesis of ITP. Next slide, please. On the other hand, we perfectly know that the platelet production is also impaired. And this is an important piece of information, because previously, when we were juniors, the classical teaching for the pathogenesis of ITP is the peripheral destruction. That's why we were very happy to do a bone marrow, the thing that we don't do now, except in very, very, very rare situations. But we do the bone marrow, hypercellular bone marrow, increased megakaryocytes. We are all happy, and this means that we have a peripheral destruction. This is not the thing that we're seeing now. We know that the TPO receptor is involved here, that we know that we have an antiplatelets antibodies and antiplatelets lymphocyte, and this results in to these antibodies to platelets that attack megakaryocytes. Also, lymphocytes are attacking megakaryocytes, also resulting in megakaryocyte apoptosis. Next slide. And this is a very nice diagram to show you on the bottom that if you look at the red arrow on the right side, showing that mature megakaryocytes from ITP patients, they underwent nuclear fragmentation, chromatin condensation to nucleus margins. If you look at this thoroughly to the right arrow, and subsequently it results in apoptosis and shrinkage and apoptosis. Next slide, please. Now, what is the clinical importance of the complement inhibition? We know that, next slide, we know that 30% of the patients with ITP remain unresponsive to current treatment modalities. And this suggests an alternative pathophysiology. 50% of patients with ITP, they have autoantibodies that activate complement or have complement detectable on the platelet surface. And this complement deposition on platelets correlates with the degree of thrombocytopenia. It's an important piece of information. 1/3 of the patients with ITP, they have substantial reduction in serum C3, C4, CH50 compared with healthy individual. And that the classical complement C1s inhibition by TNT003, it reduces complement deposition on platelets. What is this TNT003? It's a non-clinical anti-C1s antibody that inhibits the activity, and it is a precursor to Sutimlimab, the thing that we're gonna discuss in the next slide. And we know that clinical benefit has been noted in patients with refractory ITP treated with the C1 esterase inhibitor. Next slide, please. What is the evidence that we have? Next slide, please. Sutimlimab. It's the first-in-class humanized monoclonal antibody that inhibits C1s and prevent classical complement pathway activity. It is a serine, as I told you, that the C1s is a serine protease unique in the classical complement pathway, as it was shown, and inhibition of this does not allow the activation of the C3 via the classical complement pathway, but leaves the lectin and alternative pathway, the two other pathways intact. And investigators, they hypothesized that a primary mechanism of thrombocytopenia in a subset of patients with ITP is classical CP dependent, and that CP inhibition with this drug should improve thrombocytopenia. Next slide. And this was explored in an open label phase 1b study, patient with chronic ITP, where patient adults with multi-refractory chronic ITP, more than 1 year disease duration, no history of coagulation disorders, and platelet count less than 30,000, less or equal than 30,000, with concomitant medication that was allowed. A very small cohort of 12 patients. They were randomized by weight, more than 75 kilograms and less than 75 kilograms, to receive the drug at a dose of 6.5 grams for less than 75 and more, and 70.5 for more than 75, with the median duration in the range of around 14 weeks, and a median duration range for the second phase of the trial, which is the safety, and a washout period of 2 to 3 weeks. And the third part, or part B, is continuing the treatment with a median range of 71 weeks. Now, the interim results of this trial showed biweekly dose, that they were using IV biweekly dosage of Sutimlimab, resulted in a rapid, sustained increase in platelets count in patients with chronic ITP. And here is more recent long-term data for a group with more patients. Now, next slide. To summarize, that the mean platelets count increased by more than 50,000 by day 1 and was maintained while on the drug. The washed out kinetics, which is the second phase of the trial, they showed that thrombocytopenia recurred with the usage of with the stoppage or discontinuation of the drug, but platelets count recovered upon reinstitution, retreatment. And of course, based on this, on these results, the investigators concluded that these findings provide a strong rationale for further study using biologically driven agent to treat the chronic ITP. Next slide, please. Now, the second pathway that I'm going to discuss, the Fcrn pathway. Next slide, please. Next slide. What is the Fcrn system? The Fcrn system is a protective for immunoglobulin dissociation. We know that IgG dissociate at physiological pH. Dissociate on physiological pH, and the Fcrn binds to IgG in acidified endosome. Well, sorting the kind of complex that prevents the IgG to be dissolved in the lysosome. Next slide. So what was the rationale for these studies? We know that Fcrn expressed widely in placenta, hepatocytes, macrophages, and others. It's critical for IgG hemostasis, as it was said. It protects the IgG from lysosomal degradation. And that FcRn antagonists have been engineered to interrupt this relation between the FcRn and the immunoglobulin G interaction, and resulting in reduction of all subclasses of immunoglobulin G. As such, these agents may have therapeutic effect across all patients with ITP presenting IgG antibody. You know, it's a nice way to approach the problem in hand. It's like having a medical plasmapheresis. Next slide, please. Next slide. What evidence do we have in our hand? Well, I'm gonna focus on 2 phase 2 studies of FcRn inhibitor in ITP. First by Adrian, second by Tadeusz. The first drug is efgartigimod, which is a novel FcRn antagonist, and the second one is rozanolixizumab. You know, it's a little bit complicated to pronounce these, but in both studies, both phase 2 studies, the most important thing was, first of all, the safety was good. There wasn't any trend of infection and headaches, the thing that you see when you are attacking this coalition between the immunoglobulin and the receptor. No decrease in immunoglobulin M, E, A, or albumin, and it was showing a clinically meaningful increase in platelet count versus placebo. 50% of patients came on study. Of note that 50% of patients came on study with platelet count less than 15,000, which is very pertinent. And phase 3 trials are awaited, launched, and awaited. Next slide, please. Next slide. Next slide, please. Okay. The third pathway that I'm going to discuss is the Bruton kinase, Bruton tyrosine kinase. We know that, next slide, please. We know that BTK inhibition targets both adaptive and innate drivers of immune-mediated disease, which means it blocks B-cell receptors and inhibit plasma cell differentiation and antibody production. On the other hand, it blocks IgG-mediated activation and phagocytosis, as well as inflammatory mediators. It also acts on mast cells and basophils, blocking the IgE-mediated activation and degranulation. And also it inhibits activation and adhesion recruitment of neutrophils. So it's a very rich mechanism of action that we have in BTK. Next slide, please. And we know that there is a big relationship, or a robust relationship, if I may, of autoimmune cytopenias to ibrutinib in CLL, and it's being used for the treatment of autoimmune cytopenias. Next slide, please. But the problem of ibrutinib, as we all know, that we don't have data in patients without lymphoproliferative diseases. Mind you that previously we discussed that at the time of the COVID era, if you want, the old era of COVID, ibrutinib was tried to be used as an anti-inflammatory in patients with severe COVID, especially patients with lung involvement, but we don't have robust data to recommend the use of ibrutinib in this setting. But these were some observational studies that were published. The other thing that is important for ibrutinib is the moderate inhibition of platelets function, which is very important, and increased risk of bleeding. What evidence we have? Next slide. What evidence that we have? Yes. Okay. This slide is the novel oral BTK inhibitor for ITP, the rilzabrutinib. It's a more selective. It's more selective kinase, where 6 kinases are only being inhibited with this drug, and compared to ibrutinib, that is blocking 21 kinase in more than 90% of the cases. And of course, this results in less selectivity and more side effects in this setting. Next slide, please. And using this drug, if you look at on the left side of the slide, it's the selectivity and the inhibition. In the middle, it's the reversibility, because it's a reversible BTK, which means safety. And on the left part of the slide is the durable occupancy with low exposure. And this, of course, results in more efficacy. Now, the other, next slide, the other piece of information that this drug does not alter platelet aggregation in blood taken from healthy volunteer in ITP patients, compared to ibrutinib that has significant effects on platelets aggregation in healthy volunteer. Next slide, please. And if you look at the results of the phase 1/2 of the drug, you will see that in all aspects of patients that were, the duration, more than 12 weeks, less than, the completion of the trial at 12 week and 24 week, the baseline platelet count, the drug being used as monotherapy with any concomitant, with TPO, also showed a platelet response, good response. The ITP duration from baseline, less than 1 year, 1 to 3 years, more than 3 years, and the number of treatment used in an ITP. In all these subsets, the drug seems to be efficacious. Next slide, please. And the responses in 30% of the patient at 400 milligram BID, 57% if TPO naive. So it's showing that using it before TPO is more efficacious. The response is rapid, 50% at day 8. Response durable, more than
Vanessa, we don't hear any voice. Vanessa? Vanessa? Vanessa?
and the phase 3 trial, Luna 3, is underway, exploring the drug in persistent or chronic ITP. Next slide, please. Now I will finish with a couple of slides from the ASH, the last ASH 2021. Next slide, where this very drug, the results of this very drug were reported by Qatar, who's the PI, and showing safety and efficacy results for this drug. Next slide, please. And interestingly, 18 from 45 patients, which is 40%, they met the primary endpoint with more than 2 increased folds of platelet count, more than 50,000 with no rescue medication, which is very important. I think in next slide. Next slide. Well, to summarize this, another way to approach the problem in hand is to use the anti-CD38 antibody, which inhibit plasma cells. The other way to go is to use the immunoproteasome inhibitors that inhibits antibody production by plasma cells. The Fcrn pathway inhibitor already we discussed, and the C-alleated immunoglobulin that prevents macrophage FCR from clearing the platelets. Next slide, please. The use of staph protein A that inhibit macrophage phagocytosis. Btk inhibitor were discussed, and the complement inhibitor was also discussed. The recombinant TPO that can be used in pregnancy, and an oral TPO receptor, Usotrombobag, who was recently FDA approved for the treatment of thrombocytopenia in patients with chronic liver disease needing a procedure. And last but not least is the low-level laser light that we know that prevents megakaryocyte apoptosis. I will stop here and thank you for your attention.
I would like to thank Dr. Khalid Ibrahim for the excellent review and lecture. And now it's my pleasure to present my friend, my close friend, Dr. Muhammad Abeidat. Dr. Muhammad Abeidat is a consultant medical oncology and hematology at King Hussein Medical Center in Jordan. Dr. Abeidat will talk about first-line management of ITP. Dr. Abeidat, the floor is yours.
شكرا دكتور سامي وشكرا دكتور فادي for inviting me for this an educational session. But the slides is clear. واضحة السلايدات دكتور سامي؟
Yes. If you can put it full screen, please.
Yes.
Yeah, it's okay.
بس معلش بدي أطفي الكاميرا بعد إذنك.
تمام.
أيوه.
خايف نشوفك. We have 67 participants. We are proud of all of you. Really.
I will talk about the management of adult patients who with the newly diagnosed ITP. Primary ITP is an autoimmune disease characterized by isolated thrombocytopenia. البيشنت بالعادة بيكون asymptomatic at presentation. But في مرضى بيجوا mild mucocutaneous وفي some subset of patients تقريبا 5% of patients presented with life-threatening bleeding. هلا مش بس bleeding common here. Risk of venous thromboembolism is higher in patient with ITP than in general population. Also, patient with ITP reported more fatigue and impaired the quality of life. And the pathophysiology of ITP is complex, وزي ما فرجانا الدكتور خالد, and remain incompletely understood. The diagnosis of ITP is a challenge with a differential diagnosis because we have a lot of differential diagnosis of thrombocytopenia, and also a secondary ITP should be excluded. This is the chart ببين a differential diagnosis of ITP. We have pseudothrombocytopenia. Here the patient بيجي بعمل CBC بشوف platelet very low patient بيكون asymptomatic والمشكلة هون بيكون platelet aggregation due to edita اللي موجودة بالعينة البلاد. بنعمل blood film بنشوف aggregation of platelet وبيكون المريض asymptomatic with no any evidence of any pathology. المرضى renal or liver disease بيجوا بsign and symptoms of chronic renal or liver disease, myelodysplastic syndrome, acute leukemia, adaplastic anemia. هذول بيكونوا في عندهم مشكلة بالبلاد فيلم. We are diagnosed by bone marrow aspirate and biopsy or cytogenetics. في rare causes or rare differential diagnosis of thrombocytopenia اللي هو genetic disorder that cause thrombocytopenia. بيكون المرضى هذول young at presentation أو بيكونوا family history of thrombocytopenia. بنشوف بالperipheral blood بنشوف abnormal size and abnormal morphology of platelet وبيكونوا other clinical abnormalities like renal disease, deafness, and sometime in bony disorder. TTP is very important to differentiate from ITB. TTP بيجونا signs and symptoms of neurological or cardiac symptoms. We diagnose TTP by blood film. ونشوف schistocyte. We have كمان بالبلد نشوف elevated LTH, low haptoglobulin, and suppressed ADAM-TS13 level. Heparin-induced thrombocytopenia, we see them in the patient with venous thrombosis and previous exposure to heparin. Secondary cause of ITB should also be excluded before definitive diagnosis. Some certain drugs cause thrombocytopenia, including quinine, quinidine, acetaminophen, abciximab, carbamazepine, rifampicin, and vancomycin. Lymphoproliferative disorder like CLL and Hodgkin lymphoma, they are presented with weight loss, night sweating, lymphadenopathy, splenomegaly. We should exclude immune deficiency syndrome like common variable immune deficiency and autoimmune lymphoproliferative syndrome. These patients complaining test they found hypogammaglobulinemia, cytopenia, and they are complaining of frequent infection. We must exclude the infection that cause thrombocytopenia like HIV, hepatitis B, and hepatitis C virus, cytomegalovirus, Epstein-Barr virus, and Helicobacter pylori. We should also exclude other autoimmune disease like SLE, rheumatoid arthritis, and antiphospholipid that cause secondary ITB. A patient in this patient usually complaining of arthralgia, arthritis, hair loss, sun sensitivity, mouth ulcer, and thromboembolism. We diagnose them by doing some tests like ANA, rheumatoid factor, ANCA, and antiphospholipid antibody. Evans syndrome, these patients complaining of thrombocytopenia and autoimmune hemolytic anemia. The epidemiology of ITB, incidence of ITB range from 2 to 4 cases per 100,000 person per year. We have 2 peaks. The first is between 20 and 30 years of age, بيكونوا female predominance, and a larger peak اللي بيكونوا after 60 years of age with equal sex distribution. Some patients have 1 episode of ITB followed by remission, while تقريبا 70 to 80% complaining of a chronic ITB. The signs and symptoms of ITB, some patients زي ما حكينا they are complaining of major bleeding and require immediate attention, while major of ITB patient presented with few symptoms and few mucocutaneous bleeding. Intracranial hemorrhage is one of the feared complication of ITB, or usually fatal ITB usually لما يكون platelet count very low level below 30 or 20. هلا signs and symptoms زي ما حكينا they are complaining of high risk of bleeding, high risk of thrombosis. Also the patient of ITB complaining of impaired quality of life. This is a survey, ITB World Impact Survey, I wish, is a cross-sectional survey including more than 1,500 patients of ITB to establish the impact of ITP on the quality of life and productivity from patient perspective. They found that 85% of ITP patients complain of reduced their energy level. Also, 77% of ITP complain of impaired capacity to exercise. 75% also complain of limited ability to perform daily tasks. 49% complaining impact on emotional well-being, and 63% of patients their condition would worsen. Also, تقريبا half of patients complaining reduced or seriously considered reducing their working hours, and تقريبا third of patients terminating their employment. So the physician should be aware not only of the platelet count and the bleeding, but also aware the impact of ITP on the daily living and the quality of life to these patients. The diagnosis is very important, as we mentioned, and include you should take a patient proper history, you should take a family history, you should do a physical examination, complete blood count, retic count, peripheral blood, and you should exclude the secondary cause of thrombocytopenia. You should do a quantitative immunoglobulin level, a blood group, HIV, hepatitis C virus, and bone marrow in selected patients, a direct Coombs test, and H. pylori. You should exclude antiphospholipid antibody. If the patient have symptoms, you should do antithyroid antibody and thyroid function test, pregnancy in women with childbearing age, ANA, Epstein virus, CMV, and parvovirus. Also, you should exclude accessory spleen, especially in those patients that the plan of splenectomy is one of the management plan. Unproven or uncertain indication in the diagnosis of ITP is thrombopoietin level, reticulated platelet count, platelet survival study, bleeding time, and serum complement. All these tests are unproven. Patient history is very important. You should take a proper history to exclude secondary cause of thrombocytopenia, like ethanol abuse, infection, chronic liver disease, primary hematological disorder, and you should exclude with the proper history a secondary cause of ITP. You should take history regarding bleeding from previous surgery or trauma, or prior lab test of CBC. You should take history regarding drug toxin exposure and recent foreign travel, vaccination, recent infection, needle stick accident, and prior transfusion of blood products. Incidence and degree of bleeding should be assessed, and you should take history regarding contraindication of corticosteroid before establish the diagnosis and before commencing any treatment. Physical examination, very important. You should do, if you have moderate or massive splenomegaly, you should think of alternative diagnosis, because spleen size in ITP usually normal. Constitutional symptoms like fever, weight loss, hepatomegaly, splenomegaly, or lymph node enlargement might indicate another disease like chronic liver disease, SLE, or lymphoproliferative neoplasm. Peripheral blood, CBC in ITP, usually normal except for isolated thrombocytopenia. Some patients complaining of microcytic anemia from chronic blood loss. Megaloblastic anemia should be excluded because some patients complaining presented with thrombocytopenia. You should do B12 and folate level. Pseudothrombocytopenia due to EDTA-induced platelet agglutination should be excluded by peripheral blood. Schistocyte, you would see it in TTP or HUS, not ITP. Bone marrow examination is not a diagnostic and not indicated in all patients. It is performed in some patients, especially in those with systemic symptoms or abnormal sign or a suspicion of a different diagnosis. Also, you should do a bone marrow before consider splenectomy or before starting new treatment. It's indicated also in elderly patient or those not responding to corticosteroid or IVIG. Here we should do, or we could do, next generation sequence panel to exclude clonal malignancy. The bone marrow aspirate and biopsy should include flow cytometry, cytogenetic analysis to distinguish ITP from other cause of thrombocytopenia like lymphoproliferative neoplasm, myelodysplastic syndrome, or primary bone marrow failure, or even metastatic malignancy. 1/3 of patients have an increased bone marrow reticulin. However, this is not correlate with any significant, not correlate with disease severity, not correlate with clinical features or any comorbidities. Antiphospholipid antibody, which are anti-cardiolipin antibody and lupus anticoagulant, it's found تقريبا 1/3 of patients with ITP. It's not appear to affect the response of ITP treatment, and the routine testing of antiphospholipid antibody is not indicated except in the presence of symptoms of antiphospholipid like venous arterial thrombosis or history of fetal loss. ANA usually present in 1/3 of patients with ITP, and it's a predictor of chronicity and can be considered before doing splenectomy because if it is positive, it increases the risk of thrombosis after splenectomy. Thyroid function test and anti-thyroid antibody is very important before making a final diagnosis. ITP usually, or in 14% of patients presented with hyperthyroidism. Other patients have antibody to thyroglobulin, وفي بعض المرضى they are coming of hyper or hypothyroidism. Mild thrombocytopenia can occur in patients with hyperthyroidism due to reduced platelet survival, or even hypothyroidism due to decreased platelet production. And the thrombocytopenia usually resolve and restore to euthyroid status after commencing the treatment of thyroid disorder. Coagulation test, BTT fibrinogen level D-dimer is normal in ITP, and if it is positive, you should think of other diagnoses like DIC and other coagulopathy. ADAMTS13 deficiency maybe need to exclude TTP. This is some terms of ITP. Newly diagnosed ITP, we labeled from diagnosis to 3 months of diagnosis. Persistent ITP from 3 months to 1 year. Chronic ITP if the patient complaining of the disease more than 12 months. Severe ITP if we have severe bleeding requiring treatment, or new bleeding symptoms requiring further intervention or dose increase. Refractory ITP, it's a term in the past كان نحكي للمرضى اللي failed splenectomy and severe ITP. Corticosteroid dependent ITP المرضى اللي يكونوا ongoing need of prednisolone more than 5 mg per day, or frequent course of corticosteroid to maintain a platelet count more than 30 or to avoid bleeding. Durable response, you achieve platelet count more than 30 for at least 6 months. Early response, achieving platelet count more than 30 at 1 week, while initial response, achieving platelet count more than 30 at 1 month. So what's the treatment? We have 2 parts of treatment. The first part is to prevent future bleeding. In patients who are asymptomatic or mild mucocutaneous bleeding, the decision to treat or not is depending on multiple factors. One of them is the platelet count. A platelet count from 20 to 30 is used usually as a criterion for treatment. And why they choose this number? Because they found that if the patient is below 25 platelet count, the patient of ITP have 7 times more risk of admission from bleeding. While if the patient, ITP patient, platelet count from 25 to 50, they have decreased the risk of admission, and the risk become decreased from 7 times to 2.5 times. So they choose usually a platelet count from 20 to 30. But also not a number, not only this number is a criterion for treatment. Another issue you should put in your mind before starting treatment is an age. If we have a patient more than 65 age, we should achieve a higher threshold. We have higher number of platelets, history of bleeding, the risk of trauma from daily activities. الديلي activities is very important. يعني if إذا المريض مثلا we work in the office, we need a platelet count 20 to 30. إذا المريض working in the مثلا engineer, the platelet should be more than 50. While in the patient is يعني in a heavy sport, we need a higher platelet count, and this sport, heavy sport, مثلا like this. We need a platelet more than 80. Patient preference or concerns is very important issue before starting treatment. The presence of coexisting conditions such as renal impairment or liver impairment is very important before starting treatment. The goal of therapy, we have 5 goals. The treatment should be individualized to patient and the phase of the disease. Also, the treatment should prevent severe bleeding episode. The treatment should maintain a target more than 20 to 30 at least for symptomatic patient, because the risk of major bleeding is increasing below this level. Treatment should be with minimal toxicity, and treatment should optimize health-related quality of life. And this scheme showed the therapy of management of ITP, the management of initial treatment of a newly diagnosed ITP. We have corticosteroid, we have 3 types of steroids, IVIG and TD, and the patient with subsequent treatment, and Dr. Fadi will talk about this topic after my presentation. The first line treatment, we have steroid, IVIG, and rarely nowadays NTD. We have 3 types of steroid, dexamethasone, methylprednisolone, and prednisolone. For a newly diagnosed ITP and a platelet count less than 30 in asymptomatic patient or have minor glucocorticoid, minor mucocutaneous bleeding, it is indicated to treat or to observe. We suggest that corticosteroid is better than observation. But if your patient platelet count more than 30 in asymptomatic patient with or minor mucocutaneous bleeding, it is recommended to observe, not to start corticosteroid. But the number, as I mentioned, is also dependent on other factors like severity of thrombocytopenia, comorbidities, age, anticoagulant, antiplatelet therapy, and need of upcoming procedure. So we need, in the management of this patient, a higher level of platelet count. Glucocorticoid is the standard initial treatment of ITP. We have 2 commonly used regimens. The first one is pulsed high-dose dexamethasone, and the second is the prolonged course of oral prednisolone or prednisone. To compare between 2 regimens, we have a meta-analysis that suggests that platelet count higher at 14 days in patient receiving high-dose dexamethasone, but in general, overall response at 6 months did not differ significantly. While the adverse event like weight gain and Cushingoid features were more prevalent with the prednisolone or prednisone. 60 to 80% of patients with ITP and initial response of glucocorticoid, while only 30 to 50% of patients have sustained response when the steroids are discontinued. Tolerability reduced with repeated doses, and prolonged exposure to glucocorticoid is not recommended because of a wide range of side effects of steroid. This is the two commonly used regimen. We have prednisolone, 1 to 2 milligram orally for 1 to 2 weeks, followed by gradual tapering. If there is no response after 2 weeks, we should rapidly taper the prednisolone. And the other regimen is dexamethasone, 20 to 40 milligram for 4 days, every 2 to 4 weeks with maximum 4 cycles. The response rate in two regimen is the same, 60 to 80%, while the sustained response is from 30 to 50% in each regimen. If a response is seen, the prednisolone should taper, aiming to stopping prednisolone by 6 weeks or maximum 8 weeks. Even the platelet count is dropping during the tapering. If you have no response within 2 weeks, the prednisolone should taper rapidly with 1 week and stopped. Longer course of steroid should be avoided because a lot of side effects, while occasional patient may benefit from continuous low dose corticosteroid like 5 milligram or less. High dose methylprednisolone sometimes used with 80% response rate, but you should maintain your patient with oral prednisolone after high dose methylprednisolone. The steroids have a lot or a wide side effects. You should aware of side effect of steroid, like Cushing syndrome, proximal myopathy with muscle weakness, weight gain, fluid retention, diabetes mellitus, osteoporosis, tendency to bleeding, chronic immune suppression due to causing infection, stomach ulcer, and mood changes, psychotic episode, cataract, aseptic necrosis of femoral head. But every physician should be aware of side effect of steroid. The second drug is IVIG. IVIG, you have two regimen, 1 gram per kg on 1 or 2 days, 2 consecutive days, or 0.4 gram per kg for 5 days. It's appropriate in patient with bleeding or at high risk of bleeding, and or those who require surgical procedure. And in patient with the relative contraindication to high dose steroid, like insulin-dependent diabetes, uncontrolled diabetes, or psychiatric patient active infection. Also, it's indicated who are not responsive to prednisolone. With IVIG, we have transient response, like lasting from 1 to 4 weeks in around 80% of patient. Treatment can be repeated. And you should be aware of side effects and from IVIG, which include headache, aseptic meningitis, and renal failure. This transient response of IVIG allow us to starting a second-line treatment. I will review the American Society of Hematology ASH 2019 guidelines for ITP. The first guidelines should adult with the newly diagnosed ITP and a platelet count less than 30 who are asymptomatic or have minor bleeding should be treated with steroid or observation. The panel here suggests corticosteroid rather than observation. Another question, the second question, should adult patient with a newly diagnosed ITP and a platelet count more than 30 who are asymptomatic or have mild bleeding, should you treat with steroid or observation? Here the panel recommend against the corticosteroid and in favor of observation. And treatment treatment of steroid should appropriate in more than 30, appropriate in subset of patients, like those with comorbidities, anticoagulant, antiplatelet, or upcoming procedure. And for elderly patient more than 60, we need in these patients higher platelet count, more than 30. And even it is more than 30, some patient it is indicated for treatment in subset of patients. Monitoring of potential corticosteroid should be, patient of ITP should be monitored about the side effect of steroid regardless of duration and type of steroid. You should close your patient for hypertension, hyperglycemia, sleep and mood disturbances, gastric irritation, glaucoma, myopathy, and impaired quality of life. Should adult patient with a newly diagnosed ITP treated with a short course or a prolonged course, short course less than or equal 6 weeks, while prolonged course more than 6 weeks of steroid? The ASH guidelines panel recommend against the prolonged use of steroid more than 6 weeks, including the tapering. And they favor use of prednisolone with tapering less than or equal 6 weeks. Should patient with a newly diagnosed ITP treated with prednisolone or dexamethasone? The panel suggests that there's no difference between prednisolone and dexamethasone. But if you need a rapid platelet count, dexamethasone may be preferred over prednisolone because the dexamethasone showed an increased desirable effect with regard to response at 7 days, while it's not shown in oral prednisolone. Should be the patient to be admitted or to treat outpatient? الادلت with a newly diagnosed ITP يكون عندهم platelet count less than 20 who are asymptomatic or have minor continuous bleeding. ASH guideline panel suggests admission to hospital rather than to manage them outpatient. While patient اللي بيكونوا established diagnosed and known case of ITP وبيجوا platelet count less than 20 وبيكونوا asymptomatic or minor mucocutaneous bleeding. But in this case, the panel suggests outpatient management rather than hospital admission. With some exceptions, those who patient refractory to treatment and those with social concern, uncertainty about the diagnosis, significant comorbidities with risk of bleeding, and more significant mucocutaneous bleeding may benefit from admission to hospital, even if they are established diagnosis. A patient should be treated with rituximab with the steroid or steroid alone. The panel suggests that steroid alone is rather than rituximab and steroid for initial therapy. Here a remark: if high value is placed on the possibility of remission over concern of potential side effects, then initial steroid with adding rituximab may be preferred. This is a summary of recommendation. The second treatment is the treatment of life-threatening bleeding. We should take a general measures like withdrawal of anticoagulation, antiplatelet. We should control of blood pressure, inhibition of menses, and effort to minimize bleeding. In some patients who are on oral anticoagulation, it's very difficult to stopping, like prosthetic heart valve, IF, or coronary stenting. It's very difficult to stopping oral anticoagulation. This is necessitates raising the threshold of platelet count for treatment. Treatment for platelet transfusion, steroid, IVIG, or combination should be used in these patients with high dose methylprednisolone may be helpful in these scenario. Platelet transfusion can be limit bleeding, but the effect is transient effect for a few hours, and therefore patient should need to undergo transfusion repeatedly in combination with IVIG. IVIG, it's increased the platelet count within 1 to 4 days in 80% of patients, but the effect lasts only 1 to 2 weeks, that allowing you to start a new treatment or add on the treatment. Emergency treatment that are not indicated, plasmapheresis is not indicated in these patients, and recombinant factor 7 or NOVO7 is not indicated in life-threatening bleeding of ITP. The target platelet count is different from any surgical procedure. If you have dental prophylaxis, you need only 20 to 30 platelet count. If you need simple extraction, you need 30 or more. Complex extraction, you need 50 or platelet count or more. While minor surgery, you need 50 or more. Major surgery, 80 or more. While major neurosurgery, you should, the target platelet count should be 100 or more. البيشنت اللي باخده single antiplatelet or anticoagulant لازم to maintain platelet in ITP between 30 to 50, while البيشنت اللي باخده dual antiplatelet or anticoagulant the target of your platelet count in ITP should be 50 to 70. A recommendation for the pregnant lady, a platelet count more than 70 in the absence of the hemostatic abnormality. Regional axial anesthesia can be performed at platelet count more than 70. NSAID should be avoided for postpartum or post-operative analgesia in women with a platelet count less than 70 because it increases hemorrhagic risk. A platelet count more than 50 should be obtained for delivery. At women, despite having ITP or who are at increased risk of thromboembolism, should be appropriate prophylaxis for venous thromboembolism. And last, the mother with rapidly falling platelet count should be observed more quickly than those with low but stable level. So this is the talk about the first line. So which second line should we choose for our patient according to guidelines? I will present a case from my practice, and Dr. Fadi will continue to answer this question. In December 2019, a 59 female patient, known case of hypertension, atrial fibrillation, and mild LV impairment. The patient presented and admitted to hospital because of acute generalized Btk rash on her trunk and extremities. Her CBC were normal except for thrombocytopenia, and left and left was normal, but profile was negative. The bone marrow aspirate and biopsy showed increased megakaryosis in keeping with peripheral destruction. We admitted the patient and we start her on high dose methylprednisolone followed by oral prednisolone. After a few days, she platelet count become 52, so we start tapering prednisolone. After 6 months, she again presented to our hospital with severe thrombocytopenia. We admitted her again and rechallenged steroid 1 gram daily. And after a few days, she achieved an excellent response with platelet count 164. So we start the steroid tapering. And this graph shows a rapid response of methylprednisolone effect. In June 2020, platelet count 35, so we add mycophenolate to this to prednisolone of 10 milligram. In July 2020, she achieved the platelet count was 40, and this is a safe level to this patient. So we keep the same treatment. Unfortunately, in September 2020, the platelet count dropped again to 8, and so we admitted. So we start a third challenge of steroid, prednisolone 1 milligram per kg. At that time, we have Ribolate, so we combined a steroid with Ribolate. So we started the Ribolate 50 milligram. After 2 weeks of this regimen, the platelet recovered to 65, so allowing us to progressive tapering of prednisolone and keep on Ribolate 50 milligram. This is a graph show recovery of platelet count from 9 to 40 with times recover and very fast recovery of platelet count with combination of Revolade and the prednisolone. In March 2021, at this time, the patient is off steroid, platelet count 68 on Revolade, 50 milligram. In June 2021, platelet count was 80, so we choose to reduce the dose of Revolade to 25 milligram, because in the treatment of ITP, the aim of treatment not achieve normal level. The aim of treatment is achieve a safe level of platelets, so 85 very safe. In September 2021, she platelet count 75, so on 1 tablet of Revolade. And this graph shows recovery of platelet count after starting Revolade and plateauing of platelet count. In December 2021, her platelet dropped to 20. So we choose or we increase the dose of Revolade to make it 50 milligram. We gave her advice and about the diet and the dairy products, also advice on adherence of treatment. In January 2022, platelet count was 53. We keep in the same treatment, and recently we I saw this patient in March 2021. Her platelet count was 53, and I kept her on the same treatment, Revolade 50 milligram. And this graph shows the journey of this lady from the diagnosis. And with methylprednisolone followed by prednisolone, dropped again in June 2020 with re-challenge with methylprednisolone followed by oral prednisolone. And after each tapering, the platelet count is dropped again. In September 2020, we add with the prednisolone Revolade, and with Revolade, we have maintained the platelet count with the safe level. With this graph, I finished my presentation, and thank you.
Thank you, Dr. Muhammad. Excellent review.
Welcome, sir.
Excellent lecture and case. Let us go to the third speaker, and the questions will be at the end of the session. طبعا كلكم you know Dr. Farahat. Now we have almost 73 participants that we are participating with us. Professor Farahat, he is professor of medical oncology and head of hematology oncology division at Hammoud Hospital University Medical Center in Lebanon. Dr. Farahat will complete the first lecture of Dr. Abeidat and will talk about the second line management of ITP. So Dr. Farahat, you are the president and the chef of the activity. The floor is yours.
Thank you very much, Dr. Sami. Indeed, the two previous presentations were excellent. I like the presentation of Dr. Khalid, where he went through innovative treatment, and Dr. Ubaidat also exposed all indications. So thank you very much. I will continue from there, Dr. Muhammad. I will talk about second line treatment, and here is the agenda. I will talk about the surgical and the medical options, and then after we'll talk about two interesting and important study raise and extend, and then we'll talk about the principle of sustainability of the response. And finally, I will finish with another romiplostin drug, which might be interesting and important in our practice, giving more chances for our patients. I start with the splenectomy. It's the oldest way. It's the second line therapy with the highest rate of durable complete remission. Response initially might be almost 80%, and it might be sustained up to 10 years with 60% response. There is unfortunately no test to predict the response in such cases. But we have to remember that almost 1/3 of patients will relapse after this splenectomy, and we have to understand that there is a persistent increase of infectious risk in such procedure. What are the complications? It might be thromboembolic complications, pulmonary hypertension, bleeding, it might be infection, as we all know, and fever. And the mortality is low after splenectomy. I think in good hand, it's really low, less than 4% in the open in laparotomy, and less than 2 per 1,000 if laparoscopy. So this is what we have about this procedure. Now, about the toxicity, about the complication, let's say, there has been some studies showing that we can have portal vein thrombosis, approximately 2% after splenectomy, which might occur with some hematological disease like autoimmune hemolytic anemia or MPS, MPN. Just to remember that it might happen. Fortunately, the percentage of surgery is falling. The rate of surgery of splenectomy and the surgical solution for ITP is falling, and this is due to the arrival of a newer molecule and drug. And here we talk about the medical treatment. We can look to the Rituximab as the second line, which is a treatment that we used, all of us. We know very well that Rituximab is a FC mediated, is a complement cytotoxicity, is an antibody, work on antibody-dependent cytotoxicity, have an effect on T cells. We know we all use the Rituximab in different indications, sometimes in TTP, mainly in lymphomas, etc. And we know that this Rituximab might be effective in some cases, but not in all. And we see here that the median time to response is usually 2 months. So we have to remember that, because like in the case of Dr. Muhammad Obedat, when you associate a new treatment with the steroids, in case of failure of steroids, you have to keep the steroids for a while, waiting for the response. And the median time is 2 months. It might be a bit less or a bit more. And the 5-year response to Rituximab was seen at on 21%. So as you can see, if you have initially a response for those who responded, with time, this will drop. So you can have a transitory response to the Rituximab. And remember that it might be either a complete response, more than 150, or between 50 and 150,000 number of platelets. So is it really effective as long-term option, as like a second-line treatment? There is a Ritp trial, which was a multi-center randomized and which interesting double-blind trial, where they gave for the patient with platelets less than 30,000, they give them in a randomization 1-to-1 Rituximab, the classical dose, for 4 weekly infusion. That's what we use usually versus placebo. So those were patients that were corticosteroid unresponsive. In case of adult, we are not talking today about pediatric, without splenectomy. So it's the dose that you are using, the schedule that we are using, and the indication which we are using in our practice. Patients who are unresponsive to steroids. And the primary endpoint was the rate of treatment failure within 78 weeks. Okay. And the secondary endpoint were response rate, relapse rate, and duration of response. And we can see here that the Rituximab in second line for steroids failure was a bit better than the placebo numerically, but there was no difference in the primary endpoint, which was splenectomy or not. So we really do not now recommend a lot the Rituximab for such patients. And if you take a look here, you can see that the response rate was non-significantly different in the objective response rate, which means more than 50, less than 150 platelets. And complete remission, there was a difference, but numerically not statistically significant. And we can see that the median duration of response was higher and statistically significant with Rituximab, but not the CR or the treatment failure. So Rituximab as second line did not significantly reduce the rate of long-term treatment failure, nor reduce the probability of receiving rescue treatment. So as also it was said by my colleagues previously, by Dr. Muhammad, we don't aim to cure patient, we aim to sustain to the maximum a safe level of platelets. Now we have in new drugs, L-Thrombobag, second line, which is known as Revolade. L-Thrombobag is a second line treatment option in the ITP, chronic ITP. We all remember the approval in 2008 for the ITP, and the aim was to increase platelets count and reduce or prevent bleeding. And it was approved also for the previously treated patient. And then after, it was also approved for the thrombocytopenia in HCV positive cases when we have some thrombocytopenia, and we have in such cases. And also in the treatment of cytopenia in patients with SAA, which means the aplastic anemia, who have low response to immunosuppressive therapy in 2014. And in 2015, it was approved in the pediatric indications. Recently, it was also approved, in general, such drugs are now approved also in chemotherapy thrombocytopenia. A lot of experience in the chronic ITP, will not go through that, but to show that we have a number of study on L-Thrombobag, which is, that's why this makes this drug important and easy to use, because it's really frequently it has been frequently studied. And two important studies, the RAISE and the extended trials, which we'll go through now. The RAISE is Rituximab, a placebo-controlled ITP study with L-Thrombobag, and the design, it's 2-to-1, 2-to-1, because we know that, and we hoped when the investigator hoped to have better results with L-Thrombobag. That's why they did the randomization 2-to-1. Any patient with platelets less than 30 could receive L-Thrombobag or the control arm. The objective was to evaluate the efficacy and safety, and there was a stratification, the splenectomy status, the baseline ITP therapy, and the baseline platelets count, and they took the 15 as cut point, less or more than 15. And here the patient started with L-Thrombobag 50 milligram once daily, and dose was individualized based on platelet response, maximum 75 or reduced to 25, okay, or reducing in frequency. So these were the options, and we can see here that the control was either steroids, IVIG, danazole, anything could be used for such patients. And here the RAISE study, demographic characteristic, it's well balanced and for all variables, so there is no need to go through it. And we'll look to the results. It's impressive, and I think there is no need to talk about it, to explain a lot. Remember that a response was defined as any platelets count more than 50. And remember that we can go for a GYN surgery for 50. So we see very well that the responding percentage was higher in the arm of L-Thrombobag compared to the control, and it kept better for a while in post-treatment when we stopped the treatment. So almost 80% responded to L-Thrombobag at least one time, compared to almost 30%. So it's 2.5 to 3 times more in the arm of L-Thrombobag compared to placebo. And it's nice to say also that there was a rapid increase. So, so the early response, which was defined by the platelets count doubling in the first week of L-Thrombobag, and the sustaining response, which was defining by keeping the platelets level more than 50 from week 2 until the end of the treatment, were better in the arm of L-Thrombobag. So the responses were earlier and more sustained with the L-Thrombobag. And it was also important to know if we had to go for splenectomy. For all of us, we used this splenectomy as a way to treat such patients in the past. And now, even if such patient will relapse, we now have this option, because in splenectomized patients or without splenectomy, as you can see in the blue and the white curves, patients will respond very well. So those patients receiving the L-Thrombobag, even if splenectomized or not, will respond to the treatment, and will respond equally, as you can see here in the blue, the L-Thrombobag compared to the control, not to the splenectomized with L-Thrombobag. So is there any reduction of bleeding? Yes. Less bleeding in the arm, in the blue arm of L-Thrombobag, which is very important, and which is an endpoint and an aim for us. Also, reduction for concomitant or rescue medication. Yes, we can see that we have a higher level of avoiding, which means less need for concomitant or rescue medication in the arm of L-Thrombobag compared to the control arm, which is also very important for our patients. And for the quality of life, we can also observe that really it was better in the arm of L-Thrombobag. And you have to look here that for the general health, it's really worse to use this treatment compared to the placebo. So concerning the safety, we have to say that two patients were had thromboembolic events, and some had abnormalities in the liver function test. All results when the treatment is discontinued or stopped for a while. So again, all these treatments are nice, because when you stop it, the function is recovered. Total bilirubin increased more than the normal in 4% of cases, but also no clinical significant difference was observed globally between these two arms. Now we go to the second trial, the L-Thrombobag extended dosing study design. So it's many patients that were included in different trials were screened, and the number was 300 patients almost. And they started with the dose of 50 milligrams. Then after the sequential dose adjustment was done to achieve the target platelets count. So L-Thrombobag dosing initiation to reach more than 100, minimize concomitant medication while keeping the platelets 50, and also to optimize the dose of L-Thrombobag. Is it possible to reduce it and keep it on 50 and maintain the dose also with keeping a 50,000 platelets number? And the objective was to know the safety and tolerability of long treatment L-Thrombobag in adults with chronic ITP, which is important because we are talking about healthy people in which ITP will never deteriorate the situation, the health situation, unless there is a complication. So we have to look on the long-term safety. Primary endpoint, safety and tolerability parameters, including a clinical laboratory, ocular examination, and adverse event. And secondary, there was many, and also the demographics at baseline were well balanced. And here we can see that there was a high response rate with up to 8.7 years of follow-up with the arm of Revolade. So 86% of patients responded to L-Thrombobag at least once during the treatment. So which means that we are really receiving good responses and maintained. And we have 60% of the patients achieving what we call response rate, more than 50,000 platelets in the absence of rescue medication, okay, which is important. So this means that we could observe a reduction and discontinuation of the baseline concomitant medications. This is a name by itself. Remember, if you are giving steroids, remember all the toxicity. It was well said by Dr. Muhammad. And so 70% has a sustained reduction on or permanently stopped medication in the arm of L-Thrombobag compared to 52% in the arm of placebo, so which is an achievement in such cases. And we can see that there was a significant improvement in the health-related quality of life when receiving L-Thrombobag, which is also fascinating because frequently also, not frequently, but we might have many patients, young patients, active patients. So we have to take a look to the quality of life. And remember, again, these are students, universities, or functioning people. And by different scales, by different questionnaires type, we have an improvement in the quality of life. And the tolerability was good, was some headache and some nasopharyngitis, some infection and fatigue in many cases, in some cases also. So the adverse events were there and it was frequent 90%, but the percentage of disabilitating adverse events were rare. It was only 14% adverse event leading to discontinuation of the L-Thrombobag in the study. And what were mainly these? It was the liver function test, the cataract, the DVT, and the infarction of the brain, and some headaches and myelofibrosis. So in general, in the Extend trial, the toxicity profile was comparable to the previous one. And I'll skip this one because it shows some toxicity that we already know about it, but nothing new approaching this known data. So the recommended dose is 50, the 50 milligram once daily, and we keep it. If we have 50%, we can increase the dose. Sorry, if we have 50,000, we can increase the dose up to 75. If it's more than 50 and less than 200, we maintain the same dose. If it's increasing from 200, we can decrease to 25. If we are observing an overreaction of the bone marrow with increase more than 400, we have to stop the treatment. And once platelets are down to 150, we can restart with lower dose. So again, we start with 50, and if the platelets are less than 50, we increase to 75. If the platelets are responding well between 50 to 100, we keep the same dose, and it's more than 100, we reduce to 25, more than 400, which means overreaction, we decrease, we stop the dose and go back to the treatment when the platelets count is 150. You can get the schema if you want to. Certain food might affect, we know that. That's why the L-Thrombobag should be taken 2 hours before or 4 hours after ingesting the following, some dairy product, antiacid, some mineral. And it's amazing how in the majority of the drugs of the pharma Novartis, you have always to maintain, to be at distance from eating. So it's an impression that Novartis push us to do diet with many of its drugs. It's a joke just. So you have to explain to your patients the way to take this drug and what to avoid. Monitoring and discontinuation. Whenever you have a patient, you can take a look on it. I will not stop here. I will go also to the sustained response of treatment, which is important. It was proven across disease stages. So it means even if you stop the treatment, you still have you still have a response. So the majority of this study, you can see it, required achieving a platelet count more than 100 as the basis for sustained response of treatment. So you start by giving the treatment. When you reach 100,000, you may have the possibility to get a response even if you stop the treatment. Or here we can see that 32.5% has a sustained response of treatment for a median of 9 months, which is good. And the sustained response was defined as a count more than 100,000 with no bleeding for sure, and maintained for more than 6 months without additional anti-ITP therapy. So you have a third of your patient who might get a maintenance of the platelets count more than 100 for at least 6 months if you stop the treatment, which is good in my opinion. And 80 patients who discontinued L-Thrombobag in this trial after achieving CR showed that people might also keep with the CR. Remember, CR is more than 100,000 platelets. And also here you can see that the sustained response of treatment was also shown after gradually tapering L-Thrombobag. It's just to say that this drug might have an effect after stopping the treatment, I mean off treatment. And following 6 months of L-Thrombobag therapy, the off treatment, after 24 weeks of taking L-Thrombobag, the response rate was 67% and 35% complete remission. Upon treatment discontinuation, 39% and 25% after gradually tapering L-Thrombobag. At study week 52, 20 weeks after discontinuation of L-Thrombobag, which means we stopped the treatment, we still have 28% responding and 16% having a complete remission. And remember, it's defined by the level of more than 100 in this trial. So another medication, romiplostim, it's here the trial showing that in patients with balanced features, characteristic, and splenectomized and non-splenectomized patients with more than 3 prior therapy, in some cases, we might have a response. So this drug is the end plate, and we know now that we have 2 drugs that we might use with more data for L-Thrombobag. And we have to say that in these cases, in splenectomized and non-splenectomized patients, we will have some responses compared to placebo. And with that, I finish, and I will switch, if you don't mind, dear Sherman, to the quiz to see how was the impact of our presentation. Unless you want to start with the question, I don't know.
I think we can go through the quiz, and then if there is no answers through these questions, so we'll have any questions that they have our attendees.
Okay.
All of the questions will be answered, I think, through this quiz.
Okay. We have to see. Do you see the slides or not yet?
We see the slide.
Ah, you see it. Okay. Good luck, and I will. Okay, so now I will go to the quiz. The question one: which statement is true about patient with a primary ITP? Arterial thrombosis and VTE rates are nearly double than in comparable population. AT, arterial thrombosis, was more common than VTA. Most important risk factors for AT were age and male sex. All of the above, none of the above. So please read the question and give the answer. Thank you. So do we have answers? Okay, so I can see that the majority voted for all of the above. Indeed, it's none of the above. So so it's not doubled, it's increased, but it's not doubled. Okay, this is the first question. Now the second one: what may be implicated in the risk of developing chronic ITP? Is it older age, higher platelets count, lack of viral trigger, all of the above? And remember, these questions are retrieved from the important sources. So is it the older age, the higher platelets count, lack of viral trigger, all of them? What might be implicated in the risk of developing chronic ITP? So 41% older age, 12 for the all of the above, and higher platelet counts 24%. So let's check for the response. All of the above. The older age, yes, it's well known. Multiple factor, including older age, higher presenting platelets count, and lack of a viral trigger, have been considered in predicting risk of developing a chronic ITP. And for those who wants the reference, it's here, if you can ask for it. So now for diagnostic, it will be amazing here. Which of the following statement is or are true regarding immune thrombocytopenia, ITP? In laboratory testing, ITP is a diagnostic of exclusion. Massive bleeding is a typical feature in clinical presentation. So we have to get bleeding for any diagnosis. Overall mortality is estimated to be as high as 7%. A and C, B and C. Which of the following statement is true regarding immune thrombocytopenia for the adult? So is it the exclusion diagnostic, massive bleeding, mortality, or combinations? I will vote. I know the question, the answer. So here are the answer. It's really exclusion criteria. And 44 said that it might be A and C. The overall mortality is not really as high as 7%. It's less than 2%, less than 1.5. So remember, the mortality rate should be in any institution less than 1.5%. And there was a response in the chat box. Do the response to treatment with steroid help me in diagnosis? We'll come back to that. The treatment by itself will help, but there should be less than 1.5% mortality. And the bleeding is rarely, the massive bleeding is rarely, extremely rarely a sign. Which statement confirms the ASH guidelines? And Dr. Obedat went through the ASH guidelines. Which statement confirms to ASH guidelines for adults with a newly diagnosed ITP? Should all patients have bone marrow examination? Should all patients be tested for HIV and HCV? Neither of the above. Not should, I mean, should 100% of patients do bone marrow and do HIV, HCV test, or neither? Please vote. Okay. Neither of the above. Yes, yeah, 43%. The majority thinks that we have to do the HIV and HCV. But the real answer is neither of the above. But personally, in adults, I do the HIV, HCV. And remember that we have ITP in young patients. Should we do HIV, HCV for all patients? Maybe Dr. Obedat, you would like to comment in this for this question. Dr. Obedat, you are with us? Yeah. Yes?
Yes, أنا معك.
شو رأيك أنت? So the answer is neither of the above, but should we test for all patients the HIV, HCV?
And why we do these tests? To rule out secondary causes of thrombocytopenia. So I think it should be used to all patients.
Do you do it patients 15 years, 20, 25?
And we usually do hepatitis B and hepatitis C. HIV, we rarely use it because it's very rare in our country. And I think it depends on the epidemiology of these diseases.
Okay. Okay, for the, I mean, both answers were right. And the question is vague, it should be for adult, I mean, for patients above 25, I usually do it systematically. I'm not a reference in this, but I do it for patients adult. For younger patient, I don't do it always. And remember, for HCV or HPS, you should have some liver enzymes, some high liver enzymes to discuss it, or you can see on the ultrasound if there is any complication liver. So it's up to you. Both answers might be good. If there's any comment from the audience, it will be nice to hear from you. And somebody is asking Dr. Sam if they can open the mic for all to ask directly. Okay, Majdi Al-Jadaya. So here you have the answer. I should give you the question. The question is what in an investigation conducted literature review of health-related quality of life in patients with ITP, which of the following was considered a critical issue? And I was astonished to know the response. High prevalence of anxiety disorders, treatment side effects, fatigue, ITP-related social stigma. So when reviewing the health-related quality of life in ITP patients, which was a critical issue for these patients, and it was presented also by Dr. Obedat. Is it the anxiety, the fatigue, the treatment side effects, Okay, Dr. Muhammad, 40%, it's good. So I thought that it's the anxiety, but indeed it's the fatigue. It seems in different studies that the fatigue is really important in such patients. And I really can tell you that personally, I have never paid attention to the fatigue in such patients. I have never asked them about it, but it seems that it's very important. Vanessa, please, for those who would like to participate, if you can send a message, for example, Majdi Al-Jadaya, can you give him can you open the micro for him, Vanessa? Meanwhile, question number 6, what's the typical cause of ITP that develops in adolescents? It's similar to that observed in young children, younger? It's usually similar to the clinical cause seen in adult. The cause of ITP in adolescence has features that distinguish it from ITP in both adult and so is it more like the older or the younger patients? Okay. I submitted the answer, which I know already. So what's the typical cause of ITP for adolescent? Okay, the answers, Vanessa, we shouldn't stop on this question a lot. So has a feature that distinguishes from ITP in both adults and feature. The answer is it's like the young. So young people and adolescents have the same cause of ITP. We all know that in the older age, it's more hard to control the disease, not like in the younger population. Does a bone marrow biopsy make sense for chronic ITP? So bone marrow biopsy are routinely recommended as part of workup as per guidelines. Most international guidelines do not recommend. Markers of disease severity such as low platelets count, anemia, and more than one ITP medication are predictive of a bone marrow biopsy after chronic ITP. So, or you can choose A, B, C, or you can choose A plus C or B plus C. So you can read the question, take your time. Should we do it for all? Should we do it not for all? Is the severity of the disease an indication to do the bone marrow? Okay, excellent. So it's B and C 35%, and most international guidelines do not recommend. So the B, yes, it's right. The most international guidelines do not recommend the bone marrow biopsy. And also the C is correct because markers of disease severity are predictive to do a bone marrow. It means when you have such predictors for the severe disease, you have to do it. So B is right, C is right, and B plus C are. Okay. So it's B plus C. Now we'll go to the treatment. Is there any comment or question from the audience for the time?
Dr. Majdi, are you with us? Do you have any comment?
You have to give a.
دكتور مجدي, we are hearing, please.
سامعيني دكتور سامي؟
سامعينك، تفضل.
الله يعطيكم العافية. كل عام وانتم بخير جميعا. Thank you very much for the both speakers. Myself, I prefer to differ or to delay the question until the end of the session.
Okay.
Okay,
Thank you.
I am still listening and I'm really enjoying.
Thank you. You are
welcome. Thank you very much. So the question number 8, studies conducted since thrombopoietin receptor agonist producers became available, which means the L-Thrombobag, which is Revolade, and Romiplastine, which is the M-Plate. The studies show that platelet response rate among patients with ITP range from 50 to 90%. So in other terms, from the arrival of these new drugs, does the response increase more than 50% or is it still less than 50%? يلا هدي بسرعة فانيسا, you can move لأنه الجواب سهل. So it's true, yes, since the arrival of the thrombopoietin receptor agonist, the response rate is more than 50%. It's true. Now, talking about the loss of complete response to treatment in ITP. The ASH guidelines define a loss of complete response to treatment as a platelets count less than 30,000 or a less than twofold increase in platelets count from baseline or the presence of bleeding. So if the patient do a bleeding, it's a loss of response, complete response. If the platelets count from at the baseline decreased twice, it's a loss of response. I mean, if the patient get up to 100, then after 50, so it's a loss. Or if the count is less than 30,000. So is it true or false? So it's 50-50. Dr. Obeidat should interpret the slide, please. So it's true. Dr. Obeidat, some people think that it's false. Any comment?
Mark. If we have initial response, if the platelet count more than 30 or at least doubling of baseline at 1 month. في عنا early response, the platelet count more than 30 and at least doubling of baseline at 1 week. And we have more than 30 or doubling at a baseline.
Okay, question number 10, analysis of autoimmune markers in adult ITP. So which statement is right, is correct? Antinuclear antibody ANA present in 65%. Antithyroid peroxidase antibody present in 31%. Direct antiglobulin was present in 29%. A relationship existed between platelets autoantibody positivity and the presence of autoimmune markers. Remember, this is from the presentation of Dr. Khalid Ibrahim. Direct antiglobulin was present in 29%, antithyroid peroxidase 31%, and ANA 65%. And a relation existed between platelets autoantibody positivity and the presence of autoimmune markers. Okay, Dr. Khalid is not with us to answer. The right answer is the direct antiglobulin was present in 29%. And if you remember the use of the new drugs, the Btk inhibitor, it was based on the fact that the antiglobulin usually, the IgG is usually associated with the Fcn. I don't remember the receptor. So any comment from the panel, Dr. Muhammad? The ANA is for sure not present as frequently as 65%.
And found a third of patient, 30 or 33%. Antithyroid peroxidase, I think less than 20%.
Okay, so it's a tricky question, guys. Don't worry. Next question, for which platelet count therapy is required? And also here it's important. Among adult patients with ITP, those with platelets count higher than 30 do not require therapy. Is it true or false? And I think we can go quickly. So more than 30,000, do we treat? Less than 30,000, we do not treat, or vice versa. More than 30,000, we should treat or not. True or false? Vanessa? So it's true, we should not treat when we have a platelets count more than 30.
But we have some exceptions,
Yes.
older age or anticoagulants. We need a target more than 30. And even more than 30, we should treat subset of patients.
True. We totally agree. Now, in which percentage of patients with ITP steroids will resolve the problem? 50%, 70%, or 45%? So how powerful are steroids in resolving the ITP condition by giving a response at least more than 50 or better when more than 100,000? Is it 15%, 45%, and 70%? And it's correct. 50. I see that 55% voted for 70%. So yes, it's true. ITP treatment should be guided by patients' platelet level measurements rather than by signs of bleeding in patients. Remember, as Dr. Muhammad said, it's in general, it's not really fixed responses. So in general, ITP treatment should be guided by patients' platelets level measurement rather than by signs of bleeding in patients. So please vote. Hon, you have to do some work, Doctor. It's tricky because in the past we used the fact that really you don't treat patients if the platelets if there is no signs of bleeding. Okay, so here it's 50-50, Dr. Muhammad. The answer is true. So we follow the platelets level rather than the signs of bleeding. So Muhammad, in the previous, Dr. Muhammad, in the previous times, we used the fact of presence of bleeding, petechiae, سقف الحلق.
Yes.
So now it's confirmed that we have to follow the platelets level. Yes, can you comment on that? Why? And
in case of minor mucocutaneous bleeding, the في minor bleeding we يعني بنروح على target 30 or more. But في بعض المرضى بيجوا severe bleeding أو بيكون عندهم more risk of excessive bleeding أو more risk of أو history of bleeding. ف يعني بيكون التارجت تبعنا البليتلت كاونت يعني we treat even more than 30.
Okay, بس هون السؤال okay. What about patients asymptomatic and having 15,000 platelets? Asymptomatic, completely asymptomatic. When I invite you to make the difference between old ITP and the new ITP. We're talking about new cases established 1 month ago, the diagnosis of ITP, and patients failed to the treatment, and he's asymptomatic, but he has 20,000 platelets. ما عنده لا petechiae ولا signs of bleeding. عم نحكي طبعا minor لأنه in case of major signs of bleeding we have to treat. What do you think?
In case of 25 قصدك 25 يعني platelet count 25.
20,000.
And according to ASH guidelines خلينا نروح على guidelines below 30 وما عنده bleeding أو minor bleeding we should treat.
إذا ما عنده bleeding we should treat.
Yes, to prevent يعني future bleeding.
I insist on that because يعني usually in the past we used to avoid to start يعني we didn't give treatment for patients less than 30,000 if they were complete asymptomatic. Okay, thank you. So now some special cases راح نخلص. Question 14, infants' risk of neonatal thrombocytopenia. Even though ITP diagnosed during pregnancy does not worsen maternal outcomes, the infant risk of neonatal thrombocytopenia is increased markedly. Is it true or false? So the risk of neonatal thrombocytopenia is increased markedly in case of ITP in pregnant women. Or simply neonatal thrombocytopenia is increased markedly if the mother has ITP. True or false?
The trick here is in markedly.
مظبوط. Okay, the majority voted for true, and it's a true. So whenever we have pregnant women with ITP, we should think that the baby might have thrombocytopenia. And we should know also that it's not worsening the prognosis of the pregnancy, but the neonatal thrombocytopenia is there. And the last question, I think, cardiovascular and bleeding outcomes were assessed in a big number of patients with ITP, 3,500, from 96 to 2015, which statement does not accurately reflect the finding. So 6% has an arterial cardiovascular event, 3% VTA, more than 17% bleeding requiring hospital within 1 year of chronic ITP. The same for arterial cardiovascular, 6%, 3% VTE, and more than 17% bleeding within 5 years of chronic ITP. Okay, so the same, the A or B, but the duration is different, 1 or 5. Patients with a platelets count of 50, less than 50, had a greater than 2-fold rate of bleeding than patients with normal platelet counts. Again, patients with platelets less than 50 had a greater than 2-fold rate of bleeding than patients with normal platelets count. CV and cardiovascular and bleeding events were associated with a 4 to 5-fold increase in 1 year mortality. It's a tricky question. I cannot answer it personally. Okay, neither you. So indeed, let me check. So this is the answer. Cardiovascular and bleeding events were associated with a 4 to 5-fold increase in 1 year mortality. So in case of ITP and having cardiovascular and bleeding events, it's increasing the mortality. Okay, I think with that, I finish the presentation. This last one, I put it even if it's for Hispanic patients with ITP. So do you think that there is a difference in the prevalence of ITP dependent on the H. pylori, so the prevalence of H. pylori significantly higher among Hispanic patients with ITP? Why I find it's important, because you know very well that in our region we have a lot of H. pylori, and we know very well that the H. pylori should be tested in case of ITP. So do you think it's a true or false? Which means, do we have more H. pylori in ITP? The question is yes. Okay, the answer is yes. Yes, it's true. You are totally right. Thank you very much.
So thank you, Fadi.
Allah يخليك. If you want to go to the question.
Thank you. Now we'll have Dr. Majdi Jiddaya, please. Dr. Majdi.
معكم دكتور سامي، يعطيكم العافية.
الله يعافيك.
احنا هلا حنبلش الأسئلة؟
حنبلش الأسئلة.
Okay. My question to the speakers. يعني we have dealt with ITP patient a lot in our practice. Usually it is easy enough to control most of patient. Some of patient may go in challenging way to control. هلا I've been using Revolade. Why do you think the recommendation of starting an adjustment dose to trying to maintain platelet at higher level? Our aim is to keep the platelet number at the hemostasis number. يعني 30 to 50 is enough. Why do you think the recommendation to stop at 400 level and to start to decrease between 50 and 200? Why it is not on lower number? Our aim to keep it to normal, to normalize the ITP patient.
Dr. Muhammad, do you want to answer?
لا تفضل سيدي دكتور فهد تفضل.
Okay, so personally I don't have the answer, but I think that the risk of bleeding between 30 and 50 was higher. That's why they tried to get 50. And when you start the treatment, it's good to get up to 100,000, and then after you, if it goes down, is good. But whenever you have a low level of platelets, yani improvement is low, it means that there is some resistance, and you know that later on this patient will either fail or he will make more how to say it, more adverse event. So the idea again in such patients is to reach the maximum. When you start with the steroids, you try to get for a normal value. Then after, when it becomes a chronic ITP, you try to get more than 50, because 50 you are safe. Any surgery can be done at 50. Only not neurosurgical, but you can do any surgery at 50. So it's the safest level to get. Between 30 and 50, any surgery is compromised. So any accident, any trauma will be really compromising the quality of life. I think this is the reason. I'm not sure, but I think.
So why we couldn't stop below 400? If we have a patient who have 150, we could not stop Revolade on this level, even it is hemostasis controlled.
Yes, because you are not sure. You have, in some cases, you have to stop it. Here, when you have up to 400, you have to stop it. Between 150 and 400, you have to decrease the L-thrombobag Revolade from 50 to 25. And if you have later an excellent response, you may stop it, because there is a sustained response after stopping the treatment. And we show it. It's almost a third of patients when you stop the treatment will have more than 50,000. So the idea, if you give any TPO or any treatment for the thrombocytopenia and you reach 150, you decrease the dose. And if you still have an excellent level, you may stop the treatment, okay? But if the level is not reached, this means that there is some kind of resistance. The first presentation of Dr. Khalid was really very interesting and insightful, because he showed that there is different pathways for the different pathways in the pathogenesis of the ITP. So patients will respond differently. So again, I answer this way. You don't need to reach the normal level permanently, but if you can reach it, you decrease the dose of the treatment, and then you might stop it, and you might have a response, continuous response, maintained response. Have we answered the question, I hope, Dr. Muhammad?
I think this is in my point of view. If we keep the dose regimen as you mentioned, we can نفكر شيء اسمه TFR, treatment free remission, نوصل لمرحلة 400 we stop the treatment. This could be the one of the points, how to be strict with the dose, 100 to 50 to 400 platelet count. And if you achieve a higher platelet count, you could achieve in some or another way TFR. هلا المرضى اللي بياخذوا ريفولود بالعاده كمان بيكونوا ريلابس على الستيرويد، وهذول بيكونوا هاي ريسك، فانه to achieve the safe platelet count is very important in the management.
هلا finally it's personalized. Okay.
Do you have any comment, Dr. Majdi?
Yes, I got the message. The other question, in our practice, really we have faced challenging cases. Two of our patients have the paradox, have very low platelet level and major thrombosis event at the same time. He may have a major BE with a platelet count of 10. What's your option for this patient? Which to treat? Thrombocytopenia? Could you add anticoagulant on this low level of platelet?
For whom are the questions?
Dr. Fadi.
يلا حولوا لي الأسئلة الصعبة.
دكتور مجدي my colleague بالقسم، بس أكيد السؤال لك.
Okay, طيب. I think it's very tricky. But is it simply an ITP? I don't think. We observe such cases, a few cases, but in case of cancer patients, I have never seen an ITP with PE, pure. Personally, I haven't seen that. We know that the coagulation status of the cancer patients may allow to have a thrombosis So you might have ITP with thrombosis, and now I have a patient which left the ICU to the floor because he had a low platelets level 30,000, and he did a PE confirmed with the angio scan. So yes, you can have such cases, but not in normal people. I personally haven't seen any ITP in young patients without DVT doing PE. So you are confirming that you have many cases of ITP with PE. That's what you said, Dr.
No, I mentioned two challenging cases: a pure ITP without cancer, and at the same time have major thrombotic event.
No fever, nothing at all. You don't think it's there is no signs of DIC, no TTP, nothing. Just
yes. By that time, we tried to rule out a secondary cause for thrombosis, but the challenging thing is to start anticoagulant or not.
When there is a PE, you have to start. We did the same in our patient. If there is a PE, it's life-threatening. You have to do it. And specifically, we are talking about a healthy person. يعني نحن our patient did the bleeding GI because he had a problem, and nevertheless we gave him the anticoagulation لأنه the PE is fatal, so it's fatal يعني بتموته. Yes, it's life-threatening. You have to go for the anticoagulation. In my opinion, you have to do it. Now you have to explore also different other options, other exam. So you have to go for the to study the coagulation status of this patients, why he did a DVT in such cases. I mean, protein CS, etc., 83. So it's very tricky. It's rare cases. And have you searched in the literature for such cases? Is it frequent?
No, it is not frequent. In my practice, I have faced just two patients, and really they were challenging. يعني أنا بطرح القصة لأنه إحنا بنفس كنا ورد نفس الليفل by that time. We are discussing and trying to take from your experience if anything to be done more.
الريسك اوف thrombosis بالاي تي بي is يعني more than the general people. وكمان you should exclude the antiphospholipid syndrome which could be cause secondary thrombocytopenia وتعمل لك thrombosis. يعني بيكون في تقريبا third of patient have antiphospholipid antibodies positive. هلا treatment you should achieve the target platelet count more than تقريبا 50 if you want. You should combine anticoagulant with المرضى الاي تي بي. Your target platelet count should be more than 50 يعني when you treat with anticoagulant.
So can we, Vanessa, can we give the micro to Dr. Laith Lutfi? He's saying that regarding ITP patient with platelet count of less than 25,000 while on Revolade and were prone to thromboembolic event, what shall we do regarding anticoagulant? But if platelets count less than 25,000, you should stop anticoagulation. Guys, it's really very tricky, and I don't think there's a one answer. So it depends on what is the life-threatening condition. When you have a massive PE, if you have a massive PE, is the priority. So you have to keep on the anticoagulation. If it's
Dr. Fadi, could we answer some questions before taking Dr. Laith? We have here 2 or 3 questions.
Do the response to treatment with the steroids help me in diagnosis ITP? No, the diagnosis of ITP is exclusion. You should exclude any other reasons. أنا أخذت عنك, sorry, Dr. Muhammad. It is indicated. Is it indicated to start L-Thrombobac first line? هذا السؤال لك دكتور محمد. Can we start Revolade?
Yes, it's preferably to start steroid. في مرضى contraindicated to steroid, we could use Revolade, but you must أول شيء achieve the rapid response. إذا إجاك مريض very low platelets, we could use IVIG in combination with Revolade to maintain the blood platelet count at a safe level. إذا البيشنت عنده contraindication of steroid, you could use it.
Okay, so it's not regular. It's not allowed to use it unless there's contraindication or comorbidities. When you consider failure to L-Thrombobag, يلا هذه لك كمان دكتور محمد. أنا لأنه I said it in my presentation. So when do you consider that L-Thrombobag failed in your practice?
After تقريبا يعني duration it depends يعني حسب the physician. I think after 2 months, if still you have no response, you consider this a failure of L-Thrombobag.
What about the level of يعني the increase curve? So if you have a mild increase but it's taking time, لأنه the median time to respond to L-Thrombobag is 2 months. It's some patient will respond later and some will respond earlier.
So, you don't consider this as a failure. You should wait. Yes.
So it's very important. We have to wait لأنه it might take 2 months or sometimes a bit more. And the final question, is it indicated to combine L-Thrombobag and Romiplastine? Do you want to answer? Wallah.
Yeah, في some trials, but it's not يعني as standard of care to combine.
Okay, so there is no data till now saying that we have to combine these two TPO, while we can combine such medication with other, like we said, like with steroids or others. Okay, I think with that.
Dr. Laith with us?
Yes, Hakim, يعطيكم العافية. Thank you everyone for this nice lecture. أنا كان سؤال specific إنه patients with ITP on Revolade with a platelet count less than 25,000 and they were prone to thromboembolic event like a massive PE. In such cases, it's you can't put the patient on anticoagulation while the platelet count is less than 25,000. Any recommendation for stopping the Revolade as it may cause thromboembolic event? Or
it's a failure. If the platelets with Revolade are less than 25%, it's a failure. Yani, without having the thromboembolic events. So personally, I think there is no need to continue Revolade in such cases. L-Thrombobag. Dr. Muhammad.
We have many options with second line, Rituximab, as-on medication. But if you have a patient with severe thrombocytopenia, وما عندك أو عنده refractory to steroid, you could use IVIG.
They didn't continue the 2-month duration. in the first week and
يعني أعطيته steroid وريفوليد.
Yes.
Failure of Revolade.
لا عم بيقول first week of Revolade, yes.
First week, you should wait more. يعني لسه أصلاً ال ITP هو thrombogenic disease يعني ليش أنت correlate the thrombosis with Revolade? It could be due to the disease itself.
Yes, and associated factor V and phospholipids.
It could be this the cause, not the Revolade.
Yes.
So in other terms, if you exclude any other reasons behind the thromboembolic event, and you have the level even in the first week less than 25%, if there is nothing else after doing the workup, you might stop it and you have other alternative. بس لأنه if it's life-threatening يعني the PE should be controlled first, and then after you can reintroduce Revolade if you want, but you have other options.
Yes. Anticoagulation are contraindicated, I think, below 25,000 platelet. Yes. I think it will remain case by case and
unanswered. Yes, you are. We are giving really difficult cases. We cannot judge. You have to be on the يعني بدك تكون على تخت على سرير المريض. Okay.
Okay, so before giving you the floor again, Dr. Fadi, for the closing remarks, I would like to thank all our speakers, excellent speakers, Really, it's a very good information about Revolade and the effectiveness of the Revolade. So thank you all. كل سنة وانتم طيبين، كل عام وانتم بألف خير، وإن شاء الله our next activity will be May 12th, will be about breast cancer, and after that every Tuesday we will have an activity. Please, Dr. Fadi, the floor is yours.
Thank you, Dr. Muhammad Obedat, for the nice presentation and the interactive, the active participation. Thank you, Dr. Khalid Ibrahim. He had a major issue, so he can join us. But كمان very nice lecture. Thank you for all the attendees who were with us. يعني نحن برمضان ما لازم ننسى. Thank you for our president, our chairman, our friend, Dr. Sami Al-Khatib. And thank you for our كمان المترجم. Thank you for the translation in French. And thank you Science Pro for your active participation. وأهم شيء عم تتحملونا لأنه نحن sometimes we are still يعني giving them the information late. Oh, thank you again for the participant and see you next month. وكل عام وأنتم بخير. إلى اللقاء.
Thank you.
Thank you very much for all.
Thank you, Dr. Majdi, for being with us.
Thank you for all.
Thank you.